Hello, everyone. My name is Laura Sbaffi, and I am a senior lecturer at the Information School at the University of Sheffield. And today I'm going to talk about a project I conducted a couple of years ago about promoting well-being among unpaid carers of HIV/AIDS patients in rural Malawi. This is how this presentation is going to pan out. So I will first share with you the research aim that we had in mind, and then I'll spend a few words about the study location and the context. So why did we select that particular situation? And then I will discuss with you the methodology and the participants to our project, because the project was divided into two main phases, which I'm calling phase 1 and phase 2. And finally, obviously, I will conclude with the key results and some impact that the research already had. The research, by the way, was, as I said, conducted into different phases, and both phases were actually funded by the Global Challenges Research Fund, so the defunct GCRF, if you are familiar with that, which is no longer in existence, unfortunately. So the research aim was for us to support unpaid carers of people living with HIV in rural Malawi, not just in their role as unpaid carers, but also in their everyday life needs. And we did this via the dissemination of health advisory messages targeted to cover aspects of living with HIV, and at the same time promoting better health and well-being for the carers and for the people they looked after. So as I anticipated, a little bit of context about the study location and the situation, basically. So I'm sure a lot of you know that Malawi is an African country and is a very low-income country located in the southeast of Africa. It is a landlocked country, but for most of the eastern border, it faces Lake Malawi, which is the 5th largest freshwater lake in the world by volume. Agriculture is the predominant economic activity, which accounts for 1/3 of the Malawian GDP. And the country itself is divided into 3 main administrative regions: the northern, the central, and the southern regions, with districts at the sub-regional level. Lilongwe, which is the capital, and Blantyre are the 2 only urban areas in the country. The rest is virtually all entirely rural. The research we conducted was in the village of Namuera, which is in the district of Mangochi, so in the southern part of the country. And it's very close to, obviously, the border with Mozambique, actually. And the whole district of Mangochi has a population of about 1 million people, all of them basically living in rural areas. The research, both research phases, research projects were conducted in Malawi in a space of 2 years, basically from May 2019 to July 2021. And our partner on the ground was the Blantyre Institute for Community Outreach, which basically facilitated all the implementation of the projects on the ground, as I said. A little bit of additional information, a little bit of context about Malawi. It's a relatively small country in the sense that the population is around 20 million people, but the life expectancy is set at 65 years, which is in net discrepancy, if you think about it, for example, with the 82 years of the UK, where I live. And Malawi has one of the highest HIV prevalence rates in the world. And it seems currently it's 9th in the world, according to the WHO, for adults between the age of 15 and 49. Female actually tend to have a higher prevalence rate than males due to the fact that actually because of societal issues, women's rights are kind of neglected. And the cultural norms in Malawi basically implies that females are exposed to lower education levels and higher incidence of gender-based violence. The healthcare system in the country is very fragmented and patchy, with healthcare that can be considered adequate only in the two urban areas. And each doctor is expected to serve no less than 30,000 people, which is, again, a really alarming fact, considering that according to WHO guidelines, a country to be considered to have enough healthcare professionals should have at least 10 doctors and 40 nurses for every 10,000 people. So you have an appreciation of the situation in Malawi. Mangochi specifically, so the district where our research was based on, is the third hardest hit district in the country, with the exception of Lilongwe and Blantyre, again, the only two urban areas. And that's why basically we picked this particular district. And in this district, the fishing business compounded with sex inducement deriving from tourism and the very high illiteracy levels and the cultural practices I was mentioning before, which basically see the female population in a kind of further deprived position, are believed to have contributed to the levels of HIV which are currently detected in the district. So now to move on and discuss a little bit about the methodology of the participants. So what was this project about? In the first phase, which was conducted in the first year, so May 2019 to April 2020, myself and my research team from the UK went for a visit, for an initial exploratory visit in Mangochi, in Namuera, with two main purposes in mind. We wanted to identify the needs and the roles, basically the characteristics of the unpaid carers looking after people with HIV in rural Malawi. And we wanted to co-design first and co-create with them a supportive and sustainable solution that would help basically them in improving, in increasing their quality of life. And we wanted to do this, obviously, with the community dwellers themselves, but also with all the stakeholders involved in the well-being of the community. So, as I said, the carers, obviously, but also the community chiefs, because in Malawi, every village, every nuclear group of people are basically guided by a community chief. So this is the obviously the figure of power, even at very small levels. We wanted to work with the local NGOs, with the social workers, and obviously with the healthcare professionals. And we did our visit in Malawi in June 2019. And this is us conducting some of these activities during this first phase. So during this phase, we had these three activities that I'm listing here on this slide. So we started off with the focus group with the unpaid carers themselves. And obviously the focus group was moderated by a translator. And the focus group was very useful in understanding the kind of support both HIV patients and their carers get from the national and even local healthcare system. We gather people understandings of the actual medical conditions, antiretroviral therapy, their feelings about the condition, how they went by the diagnosis, and so on. And The workshop with the stakeholders that I mentioned in the previous slide was then organized at the end of our visit with the carer support groups and community chiefs, NGOs working in Malawi, and specifically we work with the Malawi Health Equity Network, with the Foundation for Community Support Services and the Baobab Health Trust. We work with two medics, two healthcare professionals, and researchers also from the University of Malawi to discuss a potential way of supporting carers in light of what had emerged during the focus group. And the idea was obviously to find a viable and sustainable solution through the lens of ICT. So in the sense that we wanted to identify a solution in line with the current and local availability of ICTs in the rural communities. Now, bear in mind that this was our initial visit, and we stayed there a couple of weeks, but it was a very intense 2 weeks, because then we went to visit all the local communities. We went inside the homes of these people. We talked to them, we shared meals with them, because food is very central to the African culture in general. And so we had the possibility to fully immerse ourselves in this study. The second phase of the study was funded by a second grant, and basically involved the implementation of this initial idea that we co-designed with all the stakeholders. And basically, after our visit, we obviously had to leave and come back to the UK. And the conversation between us and the various stakeholders continued via email, and led to the formulation of a plan to deliver these targeted health advisory messages via the audio function of WhatsApp to local carer support groups. Because during our visit, we realized that carers of people with HIV are very well organized in support groups, which they attend, which meetings they attend on a regular basis. It could be bi-weekly, it could be monthly or bi-monthly, depending on the communities. But this is where they find support and respite. And we decided to go for the audio WhatsApp messages, because although the amount of technologies available in these communities is very, very low, these communities are very poor, each community had at least at their disposal as a shared gadget, one smartphone, which could be passed through among the community members for phone calls to relatives maybe working outside Malawi and so on. So it was a shared good. And this plan of distributing these health advisory messages in this way was deemed achievable and of larger impact than just being limited to the direct participants that we had in mind, because of the Ubuntu life philosophy. This Ubuntu, which has different synonyms, it can be Amuntu, Ubuntu, so it depends on the region in Africa. But it's a life philosophy permeating Malawian, but also the whole African society in different variations. The essence of this life philosophy of Ubuntu is that a person is a person through persons. And basically, at its core, it has values like respect for all human beings and their dignity. They have a strong sense of sharing everything that is good, a sense of obedience, a sense of humility and solidarity. And basically, the Malawian society, in other words, while still promoting personal development, deeply prizes the value of the community in which each individual can strive and grow. And the second phase of our project basically deeply relied on this philosophy in maximizing the reach and impact of our initiative beyond the limits of the direct participants, basically. And this is what we did, what we wanted to achieve with our second phase, so the implementation. So we identified a range of advisory messages covering a number of health topics still related to the HIV, but relevant to the immediate needs of the carers and their families. And we developed then the advisory messages in formats, well, the audio messages, which was appropriate to the literacy level of the carers, because the language we used was very simple, but also very explicit and very explanatory, with a lot of examples. And then we evaluated the impact of the project on carers, but also on their looked after loved ones' well-being. And these are the actual activities that we did. So bear in mind that, as I said, the carers in Malawi are organized into carer support groups. So we also worked with a key local organization in the area, which was called the Namuera AIDS Coordinating Committee, NAC for short, which was established in '96 so to sensitize the community on dangers of HIV. And as part of his program of information and education, basically, established a number of support groups, 16 actually support groups to be precise. And we identified 5 of these 16 carer support groups based on their distance from the center of Namuera. So it was a convenient sampling in a way, because we wanted the carers to be able to reach where we were based with our research, and we could travel easily to them to interview them and talk to them. So it was, as I said, a convenience sampling. So we formulated 5 key health advisory messages with the support of the local doctors, medical doctors, and the community chiefs. We distributed the messages via WhatsApp audio function on a monthly basis from November 2020 to March 2021 inclusive. And 2 weeks after the distribution of these advisory messages during the meetings of the carer support groups, we traveled to the carers to interview each of them to gather feedback on the relevance, the clarity of the messages, and other aspects of the messages. Then we had another focus group with carers to identify the content of a final 6 message. So did you find the previous 5 messages useful? Fine. How do you want to integrate them with another final message? Because bear in mind, this was just a pilot study, so the time was kind of limited. Then we distributed the final message towards the end of the project in June 2021. And the project itself actually concluded with this final workshop in which all the participants, all the carers participating in the research were invited to discuss the impact of the project. And these are the 5 support groups that we involved in our research. And within parentheses are the actual numbers of participants in the project. So we had in total 94 unpaid carers working with us. And these are the actual health advisory messages that we distributed by this WhatsApp audio function on a monthly basis. So as you can see, they're all related to HIV in a form or another. And the last one, the safe motherhood and HIV, is the one that the carers themselves said, okay, this was very useful, and I know we wanted those topics, but can you also cover safe motherhood? And that's how it came by. So some key results basically from the projects. So this is just to show you a little bit about the demographic composition of our sample. As you can see, the majority of our participants were females, because again, it's part of the Malawian culture that the caring responsibilities are shared with among the female parts of the communities. 2/3 were married or in a partnership, And if you notice, almost 94% of participants were either not educated at all or only had primary school education level. Farming was by far the most common occupation. And when we asked how they perceived their own health at that point in time, almost 75% basically said that they were in good or very good health. And then the age distribution was quite balanced across different categories. So results. Participation in support groups. What we noted was, as I was also showing you in the previous slide with the demographics, more females than males tend to attend these carer support groups. So this was across all support groups, except for SOMBA, because this group actually has considerably more male participants because of a door-to-door initiative by one male member, basically, who went about, the different villages, the different communities, advising other males on the needs to be in a support group to openly discuss HIV, and apparently was a very successful individual initiative. Because the issue is that males tend not to join because, again, of the part of the culture in Malawi, the male members of the communities tend to go in multiple relationships. And if their HIV status or the HIV status of member of their families is disclosed, then they don't have as many opportunities to enter other relationships. Use of mobile phones, as I mentioned before, also, not many people had access to mobile phones. Not many at all, actually. Out of our 94 participants, only 6 had smartphones, which they shared with the rest of the community. And basically, also charging the mobile phones was an issue. So we provided Bluetooth speakers and also solar chargers as part of the project to make sure that they would be able to listen to the messages. In terms of literacy levels, only less than 40% of the participants could write and read, but at very, very basic level. And that's also why, as I explained, we decided to go for the audio version of the delivery of these messages, because listening obviously was accessible to everyone. Although some participants proposed the use of posters in further areas with literacy levels higher than the local ones, but they also suggested posters with pictures rather than words. Some very simple and explanatory picture explaining the key gists of the messages. The messages were, of course, distributed in the local language, which was Yao, but also in the national language, which was Chichewa. So this, again, increased accessibility because not everyone in the community was familiar with the national language. So that was very well received, obviously. And in terms of the message content, in general, participants said that yes, they were aware of some aspects of the messages. So, for example, they knew that washing hands was good, that eating a balanced diet was also good, and having safe sex was good. What was missing was the why. And what they found really useful in the messages was that the messages explained in very simple terms how why these actions, why these changes, small changes to their daily lifestyle would benefit them. And that's what they really found particularly valuable. And in terms of additional support, at the end of this project, during the final workshop about the impact, a lot of the participants actually mentioned that the messages, so the project obviously should continue, but the information that we share with them should also be distributed beyond the scopes of the project with the health committees, the social workers, and ideally also at Ministry of Health level. And to conclude, this is my last slide, about the impact, which we are still measuring 2-3 years later. So virtually every single participant shared the messages once they got home from their carer support group meetings with the rest of their family, and 3/4 actually shared them with the wider community. This is what I was saying at the beginning of the presentation about this life philosophy, which is called Ubuntu, for which everything that is good, everything that is of support to others needs to be shared, and this is actually shared with joy. All participants, and in this case, 94 out of 94, stated that they saw something notable, something positive in their everyday life in terms of change, deriving from having applied the advice from the messages. And they also appreciated, but this was obviously done at the end of the project, so we are still evaluating the long-term effects, but they appreciated that applying those advice on a regular basis would have much longer terms positive benefits, basically. And here I'm also reporting some comments about the messages and how they tended to share them. I now know more and I can teach others. I know how to help one in need now. Following advice will lead to safety from COVID-19. And finally, 66%, so 2/3 of the participants, as I said, would have liked to receive more messages on a regular basis, so beyond the project. And they really, really would have liked to see this kind of projects being fully supported by the Malawian government, particularly, obviously, the Ministry of Health. And that was my presentation. On a final note, only what I wanted to stress was the difficulty of carrying out this project, which just happened to be in the midst of COVID-19, indeed. So we had to make a lot of changes to our initial project. Myself and my team here in the UK wanted to be on the grounds and conduct the research ourselves, but we could not. We were not allowed in the country, obviously, and only very few people were allowed to travel from community to community, only the social care workers. And so we had to instruct them and train them on the purposes of the research, on conducting interviews, and everything needed to be done remotely and through the services of a translator. So it was an incredibly difficult project to organize from a logistic point of view, but had the added benefit and then expected benefit of extra capacity building, something that wasn't built in at the beginning of the project. So obviously we had the carers, we had the champions, we had the community chiefs working with us, and we had the local research assistants there, but we didn't take into account that also the local social workers needed to be included. And apparently as an add-on in terms of impact, they found that particularly useful as well. So with that, thank you. And if you have any questions, please let me know.